course. Well, I suppose welcome and thank you all for coming to today. We're just going to kind of run through a All Wales implementation that we've been doing over the last kind of 3 years, which is around community health pathways. So my name is Matthew, like they said. So I am the National Programme Manager that's been brought in, and I work for a company called UMA, which is a non-for-profit social enterprise based in Aberystwyth. We work with third sector, health services, local authorities to kind of do varying initiatives. And we were brought in to help NHS performance and improvement kind of implement this on the ground across Wales. And I will pass you over to colleague Dyfrig here, who's going to give some bit of context here as well.
Yeah, good morning. I'm Dyfrig ap Dafydd. I'm a GP in Llangefni and Anglesey, which is an old market town, which is rural, with a branch in Llanachmedd, which is a particularly rural area. And I've worked in Barmouth, which is near where that dispensing robot has been placed, where, yeah, we were a long way from any real district general hospital. So I have quite a lot of experience of rurality. I think the main issue I did want to focus on was the idea of the inverse care law. Some of you would be familiar with this. This was a GP in South Wales, Dr. Julian Tudor-Hart, who coined this phrase. The biggest determinant of your health is your wealth. The more affluent you are, the longer you live, and the better your quality of life or health life will be. Now, when we looked at healthcare spending and compared that against deprivation indices, what we found is there's more money being spent in affluent areas than there are in deprived areas. So there's an inherent baked-in unfairness in resources and resource spending in health. And that's particularly true in rural areas. There is a lot of, known rural deprivation and hidden rural deprivation. We know deprived areas struggle more. And, they've mentioned a few issues earlier around sort of access to services, transport, just eating healthily because your shops aren't easily available and all sorts of things. So rural deprivation is a bigger issue. And equity is a point I'd really like to emphasize, because the point behind our programme, the Community Health Pathway programme, is really around delivering top quality care across everywhere in Wales. And this is born of OECD evaluations of the healthcare system in Wales from 10 years ago, born of lots of reports. There's a renewed emphasis on quality. And so the idea is we want to know that everyone in Wales is getting the best quality care possible. And that's actually difficult to deliver everywhere. It's much harder to deliver that care in rural deprived areas than it is in city centres. It's much easier to recruit. You've got far more people in city centres. How do you make sure that you're getting the same quality of care in those rural areas? And equity means you might need to put more provision into the areas that need it most. So it's not equality, it's equity. It's saying, listen, these are deprived areas. They need extra services here to account for the fact that they're rural and they're deprived. We're working back from quality. We're saying this is what quality looks like, and every area in Wales is going to look at how do you deliver that quality for all these clinical conditions. And we are going to be picking up variation. We're going to see where there's problems with provision and service in different areas because of this programme. So the underlying drive is quality and equity. And I'll let Matt talk about the programme itself slightly, and then we've got a short video.
Yeah, so I suppose I just wanted to kind of touch base of what is community health pathways. So health pathways began actually in Canterbury in New Zealand in 2008, and it was created as I think they call it the Canterbury Initiative Programme through the Canterbury District Health. And the idea was that they were addressing the healthcare challenges within their region. The goal was to drive the kind of system-wide change in improving collaboration between primary care, community services, and the kind of secondary care provision. And what they sought for was the kind of idea of clear, locally agreed clinical pathways that would guide clinicians, that would inform patients through their healthcare journey effectively. And I think this is kind of where the ethos of the programme came from, was the Canterbury model, and they introduced it in Wales in a slightly different way, which I'll come into in a bit more detail kind of later on in the presentation. But the ultimate goal of it, as to Dyfrig's point here, was to foster that equitable care, to have one single source of truth, ultimately. And I'm just going to hopefully, if this works, in theory.
Matt's completely responsible for the IT side.
Oh, we may need to unmute the TV because it will play the sound through. Can we unmute it? If that's, or is it on here?
Sound on that, maybe. Yeah. Have a go. It'd be quiet. I'd turn the speaker the other way, maybe.
Oh, mind of its own, that.
He likes it.
In a nutshell.
Yeah.
Okay. Yeah. So effectively, it as what Jeffrey said, it's the single source of truth. It's trying to start to kind of document and understand some of that variation, and this is in a world of its own at the moment. So apologies for that. And I believe people online couldn't hear the video, so we'll make sure we drop that link in somewhere so you can see the video. But effectively, Health Pathways is a web platform. Log into it, and you've got all of the pathways that have been localized for your health board there in one place. What I wanted to come on to now is a bit of the way we've done things differently in Wales compared to other regions. So actually, Wales is first in the world actually in leading and designing pathways in what they call a pathway sharing model. So this is where we have national SMEs meeting with local SMEs, meeting with GPs, our clinical editors who are all GPs, to build the pathways, write the pathways and get them live nationally, and then localize them based off a national kind of footprint and a library. So the pathway sharing model, it's Galicians. These pathways they're localized, they're tailored to reflect local services, the resource and the referral process. The sharing model allows for pathways to be reused, adapted, and improved across Wales rather than every area working in isolation. So it's done on a kind of a once for Wales approach, and then you bring that down to your local health board and you localize the information for you. And I just wanted to kind of highlight some of the benefits we've seen to date, although it's still quite early. It's only been kind of a year and a half to 2 years in operation that we've done the pathway sharing model, but we've started to see, and this is compared to globally, so this is looking at the wider health pathways community based in New Zealand, Australia, Canada, and parts of England. We've started to see some real kind of efficiencies in the workflow. And once that's done, the site itself is a live working platform. So you as a user or anyone as an end user can feedback directly into the system, and that will go direct to the local team, who will then generate the update, or if it's required, and all our pathways are kind of on cycles of reviews, so that clinical governance remains refreshed and kind of valuable, I suppose, for the end user. So it keeps it live, it keeps it flowing. And just to move us into the next phase now, Duffy's going to kind of take you through some of the steps of how it's set up and how he would use it on a day-to-day in general practice.
So we've got that point of really focusing on quality. You want to make sure that the care you're getting is the same everywhere. And GPs can't be experts in everything. We're one of the most efficient parts of the NHS, is, if we're working well. And we know that the GP, the GMS side of the NHS used to be the jewel in the crown. There are difficulties with that at the moment, and I think something we could talk about in the breakout. But if you move on to the next slide, so if we talk a bit about just an example patient, if we want to make sure everyone is getting GPs should now be following guidelines, and there's processes in place that actually make us self-measure that at the moment. We are still looking at ways of trying to make sure that you are getting GPs following guidance. We've chosen an example patient, the skin, because we are working for the planned care team, which effectively means that my job is trying to bring down waiting lists. And so I'm the GP primary care lead, or one of the leads for the planned care team. It's my role to look at the GP referral side of waiting lists. Can we bring that down? And how do we make that more efficient? And skin's a good example, because GPs at the moment, we used to be far more comfortable with a certain degree of risk. And what we're seeing is a lot of concern around risk aversion and slightly low risk tolerances. If we refer everything, we overwhelm those services that are specialist services, and people with significant and serious issues are waiting longer because people who never really needed referring are sitting on the same waiting lists. Now, that's a contentious issue, and I know it's one that we may have discussions around, but we know that there are people being referred who could and should and would have been managed in primary care, and this is going to support those clinicians. The underlying reason that planned care teams involved is to do with thresholds. So if I choose something like a suspected melanoma, I know that the guideline is going to, sorry, you're going to jump around and guess where I'm going. That guideline is going to give clinicians advice on which suspected lesions need referring. And that's evidence-based. They will look and say, hey, you can use the EFG rule. Is it elevated, firm, and growing? You can use the 7-point that the guideline will take you if you go to the next one. So if you go to the guideline, it'll tell you how to assess, what are the things you should look for, what you should be putting in the referral letter. And what that means is that people with high suspicion lesions should be referred quickly, because you want that in cancer and suspected cancer. But you also want the people without those high risk. You want to be able to tell clinicians below this threshold, it is safe to monitor. It is safe to watch and wait and review that patient, because you want the high risk people in that urgent suspected cancer waiting list so that they're seen quick. You do not want that list full of people who don't need to be there. Now, these guidances have gone through local governance arrangements in every health board. So this will be GPs and consultants in each health board saying this is a reasonable approach to managing suspected melanoma. This is based on evidence-based, well-governed thresholds that are safe. This is what we need to aim for. It's hard to get GPs to follow that, and we are in that process of trying to disseminate and implement some of these things. When you are seeing a patient, and this is particularly relevant to rural areas, you often might not know what's available locally to you. You'd be surprised. You could be working in an area and not know that there's a service around the corner. You could be working in an area and not really know how to refer and who to refer to. And the pathways are very, very good at making sure you know, if you're in the middle of POIS, this is what we would like you to do. This has been agreed with your GP, the local medical committee. It's been agreed with your consultants. This is the right pathway for you, and how to do it, where to send things. So it's efficient, it's quick. It's not sort of trying to find an old email or look at a poster on a wall or check guidance in your desk. It's there. And for clinicians, actually, it starts to make life easier, where you know, I'm not sure about this one. You just go to this. It's got the resources that tells you exactly what to look for, tells you what's available in your area. Information for you, information for the patients. We want it to be the single place that GPs know they can go to. Cardiff's had it 5 years. It's been incredibly popular there. They're getting huge views. It's relatively new for the rest of Wales. We know this is a new programme. One of the important things to be aware of is we will be picking up the variation as we go. So if you've got a different procedure for managing melanomas in one area, you might want to question that and say, well, why is that different here? It may be better than everywhere else in Wales. If you're in Powys and they've developed a system for taking dermatoscope pictures of lesions, then we will know Powys that's slightly different to everywhere else. Why is that? And we can then actually say to various people in the commissioners in other areas and say, you should really be thinking about this area here. We have not had that robust system in place. We've had anecdotal stories across Wales, but actually a system that's recording this as we go systematically is going to be something I think the rest of the world will look at and say, wow, well done, Wales, hopefully. Kind of, what's the next slide? I've gone off on a tangent. Yeah. So it's but I think the sorts of things I really want to look at is, yes, variation, quality, equity. We think this program will deliver these things. It's new. We're finding lots of issues as we go. But then we've got with somebody actually, the group actually looking at this now. The issue of risk and governance and thresholds is an important one. If you don't have that in place, it's when things go wrong is the problem. So if you don't refer somebody as a suspected melanoma, and it is, and you haven't followed the guidance, you're in a bit of a pickle. But if you have followed guidance that's been agreed as reasonable, appropriate thresholds for management, then yes, there may be very occasional rare cases where there's something unusual. But that's the only way we can really cope as the NHS. We don't have unlimited capacity. You have to choose the right thresholds for the best quality care and equity. So
yeah, no,
through it. Sorry, but it's no,
that's good. And I'm just going to kind of give us a bit of an oversight of what the program's to deliver today. So, like I said earlier, we've been operating coming up to 3 years, and we've just had our 4th year. Hopefully agreed in principle, waiting its sign off with Welsh Government to go into year 4. And kind of the information to date, we've got 6 of the 7 health boards on board, and we're literally in the process, hopefully, fingers crossed, we shall know by the end of the year whether our 7th one will be joining the bandwagon. Within that time, really, the pathway sharing model came in probably halfway through year 1. So by the time that got underway and actually set up and operating properly in terms of development, we've been able to, about in a year and a half, roughly, or just over a year and a half, it's a bit higher than that now, but coming up to 350 national pathways, which are all available for health boards to localise. And as Dyfrig said, kind of put that local information, that agreed information, in a single source of the truth. It's been we've had a lot of feedback and a lot of engagement where it's been really useful in locums and people that work across borders, having something that's familiar, that's standardized, that they can use. As I say, you know, the utilization up there, we've hit well over 1 million views. Most of the health boards launched towards the end of their first year, so we've hit quite high utilization in a very short space of time, and we've had a lot of engagement from actually what I call the wraparound support services, so like educational patient programs and how they manage long-term illnesses, and using kind of some of their information booklets and guidelines as using health pathways as a communication tool to kind of drive some of that, because they give it to us and we're able to push it out across Wales, across the pathways, and kind of bring all of that central source of information. It's the same with Public Health Wales and some work they've been doing around diabetes and information kind of guidance for patients. Again, we've been able to use it as a communications tool. Hopefully, if we have a bit of time, we'll show you the live site itself. The homepage of the live site actually has an ability to update news feeds. It's all flexible, and each local health board can tailor that. So it'll give you stuff automatically, like this new pathway's come live, or, you know, which would be useful for a GP to know when they log in the system. But also you can tailor it for anything that's priority or anything that's focused or anything that's useful as a kind of a quick central place for people to use. Also there you'll see a nice little quote from Jeremy Miles of recent. It's been promoted quite frequently in kind of national conferences. So there's a lot of support and engagement through like the MAG reports and the enabling actions through Welsh Government. So we held an event actually back in July, and it was the first time I used to work in a health board, or in the health boards, and now sitting outside. It's the first time I've ever ran an event where I've seen quite senior Welsh government right the way through to kind of ground jobbing GP and administrative, and it's quite a small event as well. You know, it's not like hundreds of people where you don't really get the opportunity to talk and ask questions. It was quite informal, but there's some really good conversations that started to happen. So it is starting to kind of raise that profile, raise that awareness, and we have started to see some really good, well, this is all kind of initial. We've only just done our first evaluation, but you can see from some of the stats and statistics that are coming up, we've had some real great engagement, you know, over 300 people actively contributing. That's everyone, as Dyfrig said, from the LMCs, GPC Wales, pharmacy, GPs. This is everything's written and owned by a GP as our clinical editors, and then they do the engagement work to kind of make sure that the pathways have gone through that robust governance. We're starting to see a real interest from end users that they prefer it, they find it useful, it's easier than having to look at several different kind of location points to try and find information if they need it, especially if they're crossing boundaries, which is happening more and more frequent. And I think that's something, I know I live in Hull Dda. I know there's a lot of locums in Hull Dda in a lot of the GP practices, and we've been getting some really good feedback kind of around that. And we're starting to now, as Dyfrig said earlier, just kind of use the data we're giving and see how we can drive improvements. So a lot of that is coming down to the variation. We've now got a source that is standard, hopefully across the 7 health boards in Wales. And how do we start looking at those local provisions, reporting that and kind of collecting that data in the initial sense? What we do with it next is another big question, which I think is our year 4 challenge. But the fact that we've got the mechanism to do that, I think, is really quite insightful.
So we have to reflect in each area what the current practice is. So we're not the programme that says that's not best standards at the moment, but it is what's being done on the ground, because we can't go in there and change some of these things immediately. But what we are able to show is there is a bit of variation. So you can sort of say, right, we can't actually follow this pathway in BCUHB because there's a problem with spirometry provision, or we can't follow this pathway because we disagree with some of the clinical things here. And then if you're getting that disagreement between clinicians across the country, that needs discussion, doesn't it? But that's not our role. We're trying to record how things are done, where it's slightly different. That different goes away to other people who do the sort of commissioning and looking to see if they need to change services in those areas. Otherwise, we wouldn't get support from GPs. If GPs was to say to us, you're introducing a guideline and completely changing practice in our area, that's not what the job's about. We've got to be very careful of not inadvertently shifting work into general practice that isn't resourced. So we have to sort of walk a very fine line with GPs need to use it and feel that it's useful. We can't have them feel that it's a way of making them do work they weren't doing before without having resources for that. I think we are through. Yeah, we could show this on the site, and any questions, I guess.
Any questions? Yeah. And if you want to go away and have a think or get in contact with us, there's a QR code there. And basically you fill out a form and it'll come straight through to me so I can collate all the feedback. But if anyone has any initial questions.
Is it like, how do you talk to secondary care? Because from what I understand is that the discretion of the GP to use it at their but if the person driven that the patient needs to go on the waiting list, or say for example A&E, does that information go there, or is it just the clinical information, or just a help aid memo for the GP? That's how
it's an interesting one, because yes, it is useful information for the GP. We're being asked to consider more and more asking secondary care to review the referrals against the information in the pathway to see actually has the pathway been followed or not. And that's a very sensitive area because it's referral management, which is something that GPs can feel a little frustrated by. The shame sometimes is if you're waiting for a year to see somebody and the pathway gives you some information on how to manage the patient in the meantime, the patients aren't being managed as well as they could be if they were following the pathway. Cardiff has done more of that. So there has been more reviewing referrals and saying, actually, sending referrals back with advice and guidance and saying, you could consider X, Y, and Z, and the details of this are in the pathway for you. What's important about that is you can't use it as a mechanism for consultants to perhaps send something back and say, you should do X, Y, Z, which is work traditionally done in secondary care. So we're having to be very careful about how advice and guidance is used. An ideal referral would be one where somebody has read the pathway, understood the thresholds, and says, right, I'm referring this melanoma to you because it's quickly growing in size, it's irregular in shape, it's irregular in colour, it's scoring far high. Well, the consultants will read that and say, yes, this person knows what they're talking about. Of course, we need to see them straight away. But if the referral comes through as, I think this is a melanoma with no other information at all, then consultants are writing back saying, actually, could we have some better pictures? And has it got any of these features? That communication is important, but it is a difficult area. And that's where we're in discussions with LMCs, because we want GPs to buy into this. We don't want to lose that buy-in if they see it as a way of managing referrals and shifting work. But if GPs aren't doing what they could do, then we also want to try and improve that, don't we? I don't know if that answers your question. Yeah. Okay. Yes. Yeah.
My first question was going to be, which was your Southern Health Board then to find out the it's close, isn't it?
It is, yeah.
I say nothing. All direction. No. I think for Powers, it's always been, I think, more of a resourcing in terms of kind of, the other health boards are set up with an internal program team. They have 4 or 5 clinical editors who are all GPs who will be allocated X amount of time to write the pathways and build that. Powers at the moment don't have that resource, and I've been working with them quite closely over the last 6 months, really, to look at how the system can adapt for them and how we can adapt the model slightly for them to then to make it work for them in the initial. And I think it's something about kind of getting the system used and then building off of that. So they're not going to have exactly probably what the other health boards are set up like in the initial, but I think the opportunity's there, and the opportunity's there to scope out the England cross-border side. One thing I think is really useful for Powers at the moment is they will have a live site. Within the live site, as Defrick talked about, that localized in part of information, all of that information in every other health board will just be rerouted because it's already in existence. It'll be rerouted into the Powers site. So Powers will see a national pathway that isn't localized for them yet, but they will have the localizable information for all of the Welsh health boards on their border. The only thing they won't have at the moment is the England side of the fence, but it's not to say they can't. That's just about time and getting the resource. The system can do it. The tool can do it itself. It's just about kind of getting them wrapped around in that. So I'm actually meeting with their team again in December and their exec board to kind of present the business case back to them. So hopefully, fingers crossed, and if anyone is from Powers, encourage our it is. Powers, yeah, exactly. It's not straightforward. And the nice thing is, I mean, I'm trying to think. Streamliners are the guys that own the Health Pathways, the New Zealand company, but they are based across England, and there are more conversations with NHS trusts that are bordering Wales, I believe, of recent, but I don't think they've got anything live. Most of it's in the north of England, or it was down in the south at the moment. But that's not to say in a couple of years that landscape won't change again. So it'll make it even easier from a systems, because at the moment, the kind of one of the benefits of Health Pathways is that you don't have to start from scratch. There is 700-800 pathways globally that are developed in the system, so you can build off something in existence, and it's on the rare opportunity there is something that's got to start from scratch. And we do that pathway sharing. We're one of the only ones at the moment within their community that are doing this national approach, which I think is really interesting and a really good opportunity personally. But New Zealand is starting to move that way. They want to move everything into a national processing, and whereas they've got 12 independent sites that are just localized for their information and none of it's driven nationally at the moment, and they are looking to change that. But we do also share with England at the moment. So England have adopted a couple of the Welsh pathways and then localized off of it. So there's a lot of kind of cross-border, cross-boundary and globally sharing of that kind of information in that pathway. And then it's just the localization bit. And that's where Power's struggling at the moment, is the time to kind of look, as like you say, it's quite a vast landscape in terms of understanding that.
But you do have, the post GPs do have this. So they have got this. So they just see, they would see pathways based on the other areas. So if you're in South Powys, you might say, right, I want to know what the CTM pathway is for this. And you can see that. So you do have access they do have this. So if you're doing the quality improvement project in Wales on CKD, chronic kidney disease, we know that they can see that, and it's not being localized anywhere because it's simply guidance that everyone should follow. So even if you don't have a pathway in your area, you will see a Welsh pathway when you open it up. It'll just tell you this is Cardiff's pathway or this is Hywel Dda's pathway.
Yeah.
So.
Is it a pathway that sits in primary care sort of works outwards, or does it connect at different levels? And will it include the voluntary sector and community-based sort of preventative and health supporting things? Because we find in Ceredigion that getting information through to GPs is one of the biggest challenges, because they are all quite insular and you can't always find that they might appreciate the information, but you can't quite find the person to
connect it in with.
It does. There's lots of resources there for. So you might say, for example, this is perfect for a social prescribing program. Here is the details on your local program. So if you're wanting to advertise, say, something for activity or weight or even mood or all sorts of resources for dementia, resources for sort of carers, it's all, they can put that in. So the clinicians, if I want to know what is that service for autism in North Wales?
Sure, that's showing up in where's
so it's the local editors. So the GP edit, you're relying on local knowledge at the point where the GP editors are writing a pathway. But they'll usually have either an interest in that themselves, or they'll be working with. So all the pathways, when they're made, we try and get as wide a range of people involved as we can in that. So we get sort of advice or patient advocacy groups. We'd invite people from, say, Care UK, Age UK. So we try and get as many people as possible involved and aware of this pathway being written up. So we're trying to develop the chronic fatigue pathway, and that's a very complex area with lots of issues. But yeah, we want third sector involvement. We want the other areas because it's an underutilized resource, isn't it?
That's what I was just about to say. So these contact details, like I say, will come straight to me. I oversee the
we'll give you the logins, you can have a look.
Well, you can also have the logins, but I'll have so I'm overseeing the 6 health boards and supporting each program team individually. So every health board has its own program manager or project manager and coordinator who helps the kind of the back end flow of the pathway development work. We'll put you in touch with them, and then over time, because some of this is about time and building that engagement and stakeholder, because it's so vast and the amount of information out there generally as well is.
Surgeries.
Maybe you should get the dementia pathway up and see what's there. I mean, they usually have it.
Have we got what's our timing? If you want, we're staying for the day. Come and corner us. Yes. Pass the contact details on. Yeah, 100%. Yeah, and my company's based up in Ann Arbor, and 100%, and we can show you the pathway today if you want to have a look at the site itself. We'll have the login details. That's fine. Yeah, we're based up in the Aber Innovation building. Yes, yeah. I say that I'm based in Pembrokeshire, but but yes, yeah, the offices up. I do, yes. Yes, I've got very used to that 2 hour drive in the morning. Oh, I destroyed the tech. Thank you very much, guys.
From Ceredigion, I'm just going to pass on to you because we have a bit of time. Okay, thanks. So I'm going to be talking about a model that we've established in Ceredigion. It's in the voluntary sector. We think it's evolved over the years to become a really good model of meeting health needs in the community, mainly preventative. So the work that we do is mainly supporting people, helping their coping capacity and therefore reducing some of the pressure on some of the statutory services. So we've developed a model over the years, which is the second slide, where we have identified needs either through the groups that we're already working with, either individuals, participants, groups of people or other agencies. We've then worked to identify if there is a gap in service there to make sure we're not duplicating anybody else. We've established partnership links. We work closely with Simon, who's here from Age Cymru today. If we then think it's a viable proposition for us to look at developing a service to meet that need, then we'll source funds for a pilot project and we'll run that along with support from other agencies. And then over time, we will evaluate that, amend it in line with the needs that are actually emerging and, if possible, sustain it. Sorry, my slides are not transferring. No.
Oh,
There we go. Okay.
Okay, yeah. So we moved into our building in 2012 and that opened up a lot of possibilities because there were a lot of other agencies that were came in as well, and that's one of the ways that we found out different needs. We identified that there were our remit as a charity is to support the health and wellbeing of residents of Ceredigion, in particular those that are most vulnerable and disadvantaged, and that we changed our charitable objectives 4 times over 25 years, and this is what we've ended up with, which is quite broad and covers the remit that we decided best fitted our objectives. We identified that there were 4 particularly vulnerable groups in the county, which is parents of babies and toddlers, children and young people, young adults with disabilities who come to the end of full-time education, who it was made clear were then going off into all sorts of rural destinations, never meeting up with the people they become friends with over many years through school and college, and their mental health was declining over quite a short time. And then older people, in particular people with dementia and their carers. So since 2014, we've been developing services to meet those needs. So for parents and carers of babies and toddlers, we've got a 2-day-a-week family centre. It's open from 9:30 to 2:30. That's funded by the lottery. We've got a breastfeeding support group, which came out of the interests of the parents, which is funded by something else. And then we've got free lunches, which is funded by the Food Poverty Network. So it's a complete jigsaw of funding that keeps us going. So the weekly breastfeeding support group, Beautiful Minds group that was set up last year by parents of children who are neurodiverse, and soon to be established adoptive parents group who've met through the family centre. And all of those 3 groups there all came out of the parents themselves talking to our staff and us then working through that cycle, identifying the need, the gaps, and developing a service to meet that need. So these are the agencies that we connect with through the family centre. So Public Health, a nurse there diverted her hours, changed her hours of work so she could support the breastfeeding group on a weekly basis. Public Health also come in and do information sessions on various aspects of health.
Howell Bar, the health visitors have just changed their clinics to be based in our premises because they can see the really hard to reach parents that are not coming to family centre who they think will benefit. So by doing their checkups in our premises, they're breaking down that barrier of parents starting to attend. Credit Railway Carers, they support the Beautiful Minds group and come on a monthly basis to support both young carers and parent carers. Health visitors, healthy preschools, we're working our way through their prescribed units. Local authority staff team, the Parents and Families Together teams, we co-deliver parenting courses with them. 7Y have got a fantastic scheme in Ceredigion where they've got a really enthusiastic member of staff who comes out and gives lots of very personalised information on energy, and he does home visits as well. And I know that he's made a huge difference to some household bills from family centre parents. And then we also interact with Barrod Substance Misuse and West Wales Domestic Abuse, and we have open days. We invite them in, we put on a free lunch from them and the parents, and out of that we've had quite a lot of self-referrals because we've put the service in front of the parents and we know there's a need there in some of the families, and they've sat and had tea with somebody called Gemma and had a chat, and that's been enough to reduce that barrier, and a self-referral has come out of that, which we don't think would have happened unless we'd broken down those introductory barriers. And then we work closely with the SCOL team, speech and language staff as well. Children and young people, we've got youth clubs every night of the week for 11 to 18, 4 nights a week, 6 to 11s. 1 night a week, the 6 to 11 group is referrals, children that are particularly vulnerable for whatever reason, but it also acts as a feeder group into the youth club. Again, that's a patchwork of funding that's keeping that going. We set up a separate group to run 2 nights a week, which is an arts youth club, air and arts. Live band has come out of that, who for the first year called themselves the Eye Gougers, but it's now changed their name to Soap. So, and they were the most, it's really funny when I know when they're practicing and I go downstairs, and the first few times I realised it was the really introverted children that were up there singing, playing guitar, the ones that don't look you in the eye, and yet they were the ones that were up there performing. And then they call themselves the Eye Gougers, so it's like they were obviously hidden depths to their quiet ways, yeah. And then we've got a play van that goes out and about, all through, which amazing numbers of children we access through that in the thousands every year. And we go out to the primary schools and the really deprived social housing areas of the county, and that brings parents and children out. They meet each other, they don't always know each other, and it's building a real community cohesion. A couple of Saturdays ago, we put on a first youth enterprise fair where about 18 young people came along with things they made, and they made really good sales. So we're looking at setting up a young entrepreneurs club for them. We do a play day every year on UK National Play Day. About 2,000 people come, mainly local, and volunteering opportunities across all of our different projects. And Sue and Tricia, volunteers from our dementia support group, who come with me today. So with the children and families, we interact with Ceredigion Active, which is the leisure services within the local authority, and they support our play teams by inviting us to do multi-delivery of lots of activities, and they fund those sessions. They also have provided disability sports money. Primary schools, we work in the primary schools. They don't fund us, but they benefit from our activities. Health and wellbeing advisory teachers has been really supportive. Children in Need fund our youth club for the 11 to 18s. Again, we bring in Barrod and UDAS, the domestic abuse, and again, they run workshops, they cook with the children, they do different activities with the children. And asking the children after that, they said, oh yeah, I'd definitely talk to them. I definitely would talk to them if I had a problem or if I was worried about a friend. And that was on the basis of having met them and spent the day with them. And then the Children's Commissioner, we have connections with her office as well. Young adults with disabilities, we do 2 days a week. It's the best group that we run. I think nobody comes out of there with that smile on their face. They are such a fantastic bunch of young adults, and they really, really appreciate and love everything that they do. And they do everything from cooking, gardening, tai chi, dance, basketball, swimming, hiking. They make films. They are incredibly busy. And heartbreaking, because we are threatened with closure next year, even though we turn 25. The lottery basically said you've had enough money from us, and we're really struggling for funding next year. And it's heartbreaking what the families feel the impact will be on their young people if we're not able to keep that group going. We don't interact with many services with the young adults with disabilities. The Ceredigion Active have diverted some disability sports money to us for the last 2 years, and we get referrals from social services. But we are in talks with our local authority to look at models across Wales where direct payments is funding a service rather than individual one-to-one, because potentially that could be a way to sustain it financially after our lottery money ends in March. And there is a slide which, if this presentation gets circulated, you'll be able to read it. It might be quite hard to read because there's such a lot of text on the screen. But it was an unsolicited email from a parent who'd heard rumours that we were facing financial difficulties, just documenting the impact attending the group had on her son. And I think he might be the individual that came who we were told didn't speak, and since coming is talking, going swimming, interacting in lots of activities and beyond the expectations of his parents. And you know, he's in his 20s, so and I think that is down to the staff that we've got and the way that they plan and deliver the activities and the enthusiasm from the group as a whole. And then for older people living with dementia and their unpaid carers, we have a weekly group, which both Sue and Trish volunteer at. Fantastic team of volunteers. It's a really nurturing group, and for some carers, it's the one time in the week they can walk in, get given a cup of tea, and actually put their caring responsibilities down for 3 hours. And people have said things like, this is life-saving. And then that group got so busy with people still coming, even though the person with dementia had passed away and gone into long-term care, that we actually were able to work with Age Recovery on some pilot funding that had come through Welsh Government, set up a new carers group. So on a Thursday, if you're not bringing anybody, that's your day. If you are bringing somebody, your day is the Friday. And we do find that for people who've been caring for a long time and that person passes away or goes into long-term care, that is a hugely difficult time. And for a lot of the people of the generation that we're dealing with, it might be the first time they've ever lived alone. So they're facing a big change in circumstances, and they're feeling a mixture of guilt that they've let the person go into care, a little bit of relief because the caring role is so intense. So being able to come together and speak to other people who are in that same circumstances is hugely beneficial. So we work with Ceredigion carers. They come on a monthly basis. They do generalised support chat to the group, but they also can go out into a smaller room and do one-to-one personalised support for carers. Living Well with Dementia, which is that scheme is managed by Age Recovery, so they are now directing people to us at diagnosis. Bereavement support, that's another scheme run by Age Recovery. They're supporting the carers group. So we had funded, we worked with Age Recovery on that pilot for the carers group, which we've been able to sustain with further funding. Admiral nurses come along and support us, and we can refer to them. The community connectors in the local authority come in 7Y again will come. And lots of agencies come, like the ambulance service. We're piloting changes to the inside of the ambulance when they're transporting people with dementia. So they came out and they piloted it with our groups. Quite a lot of people come along to carry out their own research with the group as well. So the benefits of our approach are that it's free of charge at the point of use. Our premises are inclusive, accessible location and premises, and since we've been in there, we've probably put in around £200,000 of funding to make the premises more accessible and inclusive. One of the main advantages of what we do is we create peer-to-peer support. So people come along who are facing similar circumstances, and just by meeting somebody else and being able to talk about it builds their coping mechanisms. They go out feeling stronger, and those friendships can extend beyond our sessions and can become really strong friendships, which is good for people's health and well-being. Our trained and supported staff add value to the sessions. They know a bit about the people that they're dealing with. They can make sure that they make the environment suitable and the activities. And then another hugely beneficial aspect of what we do in such a rural area as Ceredigion is external agencies can come to us and they can find a whole cohort of the people that they support. This can be the health visitors, it can be the admiral nurses. They've got a whole room full of people, whereas if we weren't there, if we don't exist, they've got to try and find those people in a really rural area, which is going to add in lots of costs, but also mean a lot of those people will be missed as well. And we offer enriching volunteering opportunities as well. And our youngest volunteer is 12 and our oldest is approaching 90, and we've got see the figures in a minute, the amount of volunteers we've got. The challenges are that funding model is always short term. There's very few opportunities that suit the rural area, and there's a really interesting study that's just been launched called Pretty Poverty by Plymouth academics, and it is pointing out that the rural model, the indices we've got for deprivation do not reflect need in rural areas, and their study is based on Cornwall. It's Dr. Tanya somebody. She's very willing to interact with anybody who's got case studies or who wants to feed into her research about that. So the lottery saying they don't want to fund us anymore actually means that there is hardly anybody else who will consider the way that we operate, because our numbers are quite low. Most funders looking for big, they're one-issue funders. They're looking for big numbers of homelessness, big numbers of substance misuse, big numbers of this, that, or the other. We've got smaller numbers, and it's quite dispersed. And by making everything we're doing inclusive and universal, it means we do bring in those people who've got the higher needs. But if we were to try and focus on just one need, we'd have about 8 people. So it wouldn't work. So we are meeting those needs, and we think our model really, really reflects the area that we're in and is fit for purpose. Yes, so the deprivation statistics don't recognise rural issues. The voluntary sector, I mean, I'm fed up with the amount of strategies I get that get put in front of me that say this, this, and this, and then the solution is the voluntary sector. And I say, where's the money? Oh no, we haven't got any money. The voluntary sector will do that bit, and we're the answer to all the problems. Nobody wants to fund us. And we are the answer to the problems. We're creative, we're not bogged down in bureaucracy, we can move quickly, we're really cost effective because we're on really low wages. But there's no really hard to get funding to carry on doing what we're doing. So there's a lack of statutory co-working. We do work with all these agencies, but it's not very coordinated. I would like it if all of the strategies and the delivery models were mapped much better into us, and our results were being recorded much more consistently and fed back into the statutory sector. I think that's a bit of a missed opportunity. And then somebody in our network in Ceredigion have a food surplus described us as vulnerable organisations who our remit is to support the vulnerable. And I think that does describe it really well. So the numbers that we're interacting with here, that's for this is for our lottery funding project. So it's year 1 of our lottery funding project in year 2. So it's April to March figures. But it's really impressive, the numbers that we've interacted with. We've now got over 100 volunteers registered, and you can see the volunteering hours that they contribute in a 12-month period is really impressive as well. The play van gets out and about, and also I said the other day that the play van hits really big numbers, but I don't really want to say play van hits. But we do get that to a lot of people. I tried doing, I don't know how accurate this is because I did it quite quickly over the weekend, but I tried to do a kind of cost benefit of what we do, and this, I probably need to look at this a bit more closely. But it was a figure based on what our expenditure is in a year, because we've got about a team of about 20 staff doing all the different activities that we do. We also lease our premises, so we have to pay that out, and all the different costs. We've got a minibus, we've got a van, we've got a lot of outgoings. And so that's the money that we spent in year 1 and year 2. Probably got about 13 different funding sources that make up that figure. And then I tried to work out a cost per person per year, but I think it is cost effective in terms of, and that's primary beneficiaries. And for every person that comes through the door that we've actually got on a piece of paper, so we've recorded that in writing on a register. We can source the figures where those numbers come from. But for every one of those, there are secondary beneficiaries. So for the couple that come, the person with dementia and their carer, we get phone calls from their daughters, their sons, the wider family, just saying, "Oh, it's such a relief our mum's found you. You know, we're not worried so much that she's got somewhere to go each week." And a dad said to me, "I come home to a happier house when I know my wife and child have been to family centre, because I know that they've had a good time and the home will be happier because of it." So if you look at the secondary beneficiary impact, those numbers are even higher. And then I started looking at some of the strategies that we're delivering on. So there's 2 slides there of strategies. And then somebody from our CVC sent me another few strategies there that she also thinks we're delivering on. And then we just got some pictures. So that's our building in Aberystwyth. We've put so much into it over the years that it's really suitable for multi-age, multi-ability. Just got a grant recently for over 20,000 to replace the wheelchair platform lift to get people into the building. We've got, it's suitable for everybody from the breastfeeding group to the dementia group. And then there's a picture there of the family centre. We put on free lunches for them twice a week, and we put on free meals every night for the youth clubs, the 11 to 18s and the 6 to 11s, with lots of healthy snacks as well. Our staff have been trained by the community dietitians. Then we've got a picture of the younger youth club with Dave from the men's shed on Age Without Limits Day, when he came down and made some wooden boats with them. And then we've got a picture of the eye gougers performance at the Ray Play Day. And that band wouldn't have happened without us doing what we do. And then we've got a picture for a play van. The play van being out and about. And we model like low cost resources, and we do a lot of free training and play work training as well, which parents say really changes their attitude to children's need to play and development. Somebody donated a lot of Avon boxes, so we took all the boxes out in the van, and there were so many different things depending on where we were, and that's just a car steering wheel from scrapyard. And then we've got a picture of the Demone group, which is a group of young adults with disabilities in our yard. And we've got they look after our greenhouse and our wildlife garden, which we've made on a tarmac cart, which used to be the car park. And then we've got a picture of the dementia group out and about. And the man with his back to us has got dementia. And I just really like this picture because he really loved helping people and being useful. And then we've got a picture of the carers group. And then we've got 2 pictures of us celebrating Volunteers Week. And Ellie in the purple t-shirt on the right, she's our volunteer coordinator and helps recruit all of these people. And the mayor came along. And then if you go on to the next slide, there's a young girl standing next to me, that's Savannah. She's our youngest volunteer, and in front of her with the pink hair is Abby, who's our oldest volunteer. So we've got a really good age range of volunteers as well. And that's an incredible contribution to people's health and well-being as well. Because whenever we say to the volunteers, what do you get out of it? They feel it's giving them a purpose, and they're still able to use the skills and experience that they've spent a lifetime building up for the older volunteers. And for the younger ones, it's really helpful in developing a CV and skills in working with all sorts of people of all ages. So I think the point I want to make is I think we are delivering health and care. We are working across different sectors with multi-agencies. We're struggling for fundings, and which is frustrating to me because I think we're delivering on a lot of outcomes. The NEST outcome, I'm always going places and the outcomes are described and we're putting them into practice on the ground, but there's no finances to support us to do that. And I would like to see us in particular working in a bit more of a streamlined fashion with the statutory sector, so that the work that we do is mapped effectively against these strategies without, it's a lot for me to try and do that because I haven't developed the strategies and I can't be an expert in every strategy that's out there. But it would be good if we were recognised and seen a bit more within. And yeah, that's my presentation. Thank you very much.
I'm very sorry, I'm afraid we won't have time for questions.
Okay.
But if there's any questions, either put it in the chat or if you send it to me, and then I'll forward it to Jill.
There's a few paper copies there if anybody wants a paper copy.
Okay, lovely. Thank you very much for asking us to come and talk. So yeah, my name is Anne Harrod and I'm one of the lecturers in Aberystwyth University, and I'm joined by Kyrene and Hannah and Kaylee today, which is lovely. For perhaps some of you who don't know, we're really new on the nursing education sort of platform. We started around 2022 with our first cohort, and they qualified in the summer this year. And we offer adult and mental health nursing. And when we were developing the curriculum sort of pre-2022, we had a blank page. It was a gift of a position to be in, because most nursing provisions now, they exist and they get tweaked and they respond when things change. But we were in a position when we were devising the curriculum where we had nothing, and it was this real gift really that we could think differently and we could think outside of the box. Absolutely. And that was one of the main drivers really, and it certainly was one of the key sort of mantras in what we were trying to achieve, was to dare to be different within our curriculum provision, because we are unique in relation to perhaps our geography, the size of the cohort, and obviously in terms of some of the provisions that, we're not a big urban tertiary centre. So we were able to think very much about responding to rural needs and making sure that was reflected in our curriculum. So we had this lovely gift of a blank page really in terms of curriculum. But having said that, we are very aware that we have to adhere by the Nursing and Midwifery Council guidelines and standards in relation to we are producing competent, safe, registered nurses at the end of the 3 years. So whilst we were daring to be different in terms of our mindset, we were also focused in terms of the educational standards that embed nurse provision and nurse education. So with that, we're obviously looking at health and the provision of health services. And really little has changed since 1948, since the World Health Organization presented this definition of what is health. And if you start to look at sort of the trajectory of health, and certainly the statistics in this day and age in terms of, you know, where we are in terms of health, the health of the nation on a global stage, it is really a negative trajectory in terms of death globally, in terms of the burden of disease, and the statistics there. I'm not really going to go through that today because that's not what we're here for. So our students, they are taught these things because they are important within the nursing curriculum. But at the same time, we were wanting to think of different models of health because we were able to be in a position where we could put perhaps a different perspective on how we respond to these health needs. There's obviously different impacts when we're talking about the burden of disease as well, and that could be financial, and there's a slide there, and again, that's what we're not here to talk about that per se, but it was certainly an influence when we are thinking about our curriculum and the different models of health that we were wanting to present within that. And there were other impacts as well that kind of influence health provisions that we didn't want to lose either. But this is the reality of health in terms of statistics, and the reality of health service provision is very much a reactionary focus in terms of responding to health needs as they arise. But also there needs to be a different way to think about how we respond to some of these. So within our programme, we were, like I said a bit just before, about daring to be different. So we were thinking about, within our curriculum, we could be quite bespoke, we could be quite innovative and creative in the provisions of educational content, responding to those needs, but also thinking about different approaches that we can share with our students. So this Dare to be Different gave us sort of this permission, if you like, to be different, to be innovative and be creative in terms of what we were trying to give our students. And we also wanted to reflect different aspects of modern healthcare. So yes, we're very much placed within the context of those health concerns that are very much an issue globally. But we wanted to think about different approaches as well within nursing that gives our students different tools within their toolkit, really, and to really think outside the box when we are having to respond to different needs as they arise. But like I said, whilst we're doing that, we didn't want to lose sight of the NMC requirements because nursing is a regulated profession, even though our students are not regulated, us as educational providers are. So we were not losing sight of those NMC requirements either. But we also wanted the curriculum to have fun elements because nursing, working in healthcare is challenging, it's very rewarding, but it is a challenging platform. So we wanted to give different experiences to our students. So the drivers for change really is that if you do what you've always done, you will get what you've always got. You've heard me say that this morning, we were teaching this morning. So if we just did what everybody else was doing, then, you know, we're not daring to be different. So we were wanting to be a bit creative in relation to what our curriculum looks like. So that kind of led us then to social prescribing. So I've been aware of social prescribing for quite a while, really. But again, it's not something perhaps from an educational point of view that our students are overly exposed to in an immersive way. And this is just some statistics here about what social prescribing is and placing it within that sort of model of health that moves away from a medical model of health and placing it into more of a well-being, resilience, self-care element, which enables people. So that was really something really that we felt that was important to embed within the curriculum. But having said that, we wanted it to be different as well. Our students, bless them, you know, they're sitting in front of us as lecturers in a very much talk and talk environment for a lot of their lectures. Clinical skills lectures are a little different. But again, we were wanting to place the social prescribing element within a very different sort of classroom learning. So this is just a picture of what we've been able to do over the last sort of 3 years, really. And we were really enthusiastic when we were thinking about social prescribing and thinking what it looked like for our students. And over the last 3 years, I would say, we have been fortunate to work with different companies, different organisations, different partners within the university as well, because we've been able to tap into really key expertise within there to make that learning fun. So this is just a flavour really of the last 3 years. We were able to take our students out for an immersive woodland project. We work with the agriculture and the vet section within the university as well, for a lambing experience. We take back to the lamb sheds, because Aberystwyth is very in a unique position where we have commercial farms, and we look at the mental health and emotional well-being of the agricultural communities. We have organisations, car mechanics, pet therapy as well. So again, thinking about what health looks like in a very different environment, and thinking of how to make that learning more meaningful for our students. So that's a flavour of what happened in the last 3 years, really. But curriculum going forward, we've been in a very unique position again, where our commissioning numbers have increased. We've only started 3 years ago, and our commissioning numbers have increased. From a point of view where we had to think about curriculum going forward, we needed to future-proof our content in terms of making sure that all our students have a replicable experience, and it's scalable as well, so that if we're doing an experience, then it should be equitable for everybody. Equality of provision, so that students get all of the provision, and it's sustainable going forward. So we had to rethink, in the case, we had to rethink some of our sort of approaches to our curriculum. So we had to go back to the drawing board about some of the social prescribing content that we had planned previously, because of the scalability of it. So we were thinking about what sort of things we could put in the curriculum that could be replicable going forward. And we were having different conversations with the sports department.
And it was about control as well.
Yeah.
Because what we'd done previously was out of our
control. Yeah.
So we were trying to make sure that we had control of what we were doing.
So we were having conversations with our sports department about doing different sporting activities, or perhaps more wellbeing activities. We were thinking about mindfulness. We were thinking about woodland walks and things, and then that's very much dependent on weather. And here in the Midlands, if we have a day where it's pouring with rain, and we have a day of activities outside, going to work. So then we came down with plan B in terms of, well, if plan A didn't work, we needed a plan B. And actually plan B turned out to be more doable, because I think we invested more in our plan B than did plan A. And then we said, why don't we just go with plan B? So this is kind of where we led. And I was very much led by Kay's in this sense, because she was the key driver, because you love knitting. Hayes is our knitter in the team. And then we were trying to sort of unpick then knitting as a social prescribing.
Intended.
Yeah, indeed. So we were trying to think about knitting as a social prescribing project, and we found lots of different research that looked at the benefits of knitting, and there's just a list there really in terms of the health impact, and it's not a health service, it's not something that you go to the GP service for, it's not a prescription. And this is there for, for our students to learn about, but also there for our residents, the population, to again think differently about how they manage their healthcare needs. So this was kind of a driver for us then, with Kay's being the knitter of the team as well, and thinking about sort of linking it up to the health benefits of what knitting could give people to support their well-being. So this was plan B. So like I say, we were humming and hawing with lots of different sort of options of what could be doable in the future. And then this kind of just opened naturally, didn't it, in terms of what we could be providing. So we were now going to do a knitting project.
Yeah, so Anne was right. Plan B fastly became plan A, and it was like, okay, we're going to do this. We were committed. So it was like, how are we going to deliver this to circa 80 students that may or may not have knitted at this point? We didn't know we didn't really want to show our hand yet to the students what we'd like them to get involved with. So it was how logistically we were going to go about that. So we decided we'd go 10mm needles for the knitters in the group. We'd go super chunky wool so that we could achieve something in a day with 80 students who may or may not be able to knit. So off we went around all of the charity shops to see what we could gather. We didn't have much of a budget.
We did not.
Part of the appeal was that it would be self-contained.
Yes.
We would be able to keep replicating it, hopefully out of monies that we may or may not raise, she says. I'll let Anne have a talk about that. So off we went around all of the local charity shops, gathering things as we went. And the aim was, if everybody could knit one square, we could put the squares together and potentially come up with a blanket in a day. So that's what we were going for. And I was merrily going along. You know, I taught myself to knit because I was born with being on my mobile phone. So it was hitting all of the pluses for me. And as I was chatting with people in the shops, telling them what I was trying to do, their faces toned my enthusiasm quite a bit, because they were like, "You're going to teach 80 people to knit in a day?" And I was like, "Yeah," because that's what everybody does. And they were like, "No." I was like, "Right, okay, I'm sure we can do this. We've got the capacity, we're in." So thinking about the logistics a little bit more, right, I'll pass on before everyone gets there. It all becomes 40 people in the morning, 40 people in the afternoon. I get my mum round for the weekend. "Come on, mum, let's do some casting. Lovely, happy as Larry. And yeah, and it kind of like got a little bit of impetus in there.
It did, and there was real whispers around the university of what we were doing. There was real momentum then, because the psychology department cottoned on to what we were doing, and they were very keen to understand the concepts behind it. Our student wellbeing services were really keen. They were involved, wanting again to learn more. So the more that we were trying to keep it under wraps, because our students didn't know we were going to do it. But certainly the momentum behind the scenes was really gathering pace at that point.
We also had, we've got the healthcare education network as well as the barista. So
Yes.
we've got some local people that are sort of like bought into what we're trying to achieve.
Yeah.
I mean,
And I think that was really important for the actual. So so business mentoring our HENA group, so Healthcare Education Network Baristers. So they are our patient and service user partners. So they're part of our network, and they help in all sorts of aspects of the curriculum. But we did a reach out as well to knitting groups in the Aberystwyth area, and we were able to recruit a good number of ladies from knitting groups that were really thrilled to be involved. So we had their back as well, and which was good, because we can turn it into more of a gown and town project then, in relation to people in the community working with us as well. So that was really important. So we timetabled it as social prescribing. So we didn't mention about the Knitting Pretty project or anything like that. We didn't want to put people off. We had 80 students registered from last year. So this is why we had to think about how we were scaling it. So we split them into two groups, 40 in the morning and 40 in the afternoon, and they were in the very content. So we had just said it's social prescribing, and we were just focusing on sort of unpicking that. So as I said, the HENA members were involved, and actually by this time, all the HEC, we call ourselves the Healthcare Education Centre team, so all the HEC team were really keen to be involved as well. One thing we wanted to source was a different classroom. So we have a specific classroom where we teach lead lectures, but we were really keen to take this session out of the classroom. And the first year we ran it in Pontycelyn, and last year we ran it in the visualization centre. So we took it out, and that really just was a positive sort of environment for students, because we wanted it not to be a classroom taught session. We wanted it to be informal. We wanted students to talk to each other. We wanted them to talk to our HENA members. So it was very much a different kind of session. And also I have One Health contacts from around Wales, and they were really keen. Sarah and Mark were really keen, and we had conversations as well. So again, these buy-ins about what we were doing was something very, very different, and which was really exciting for us. So the session, we in order to we're not going to invite students and say, hey, we're going to do knitting, because that's not going to give them any context to why we're going to teach them how to do knitting. So within the session, we did group work to start off with, just to place social prescribing within the social model of health, within why it's important. So we split the students up into groups, and we gave them different questions to answer. They were allowed to bring their devices in to help them research or look up the question, and then they presented back to the group. And that took about an hour, I think. The session in total was 3 hours. That took an hour really just to place it into some sort of context about why it was important, and also the students have a bit of background to why we were doing what we were doing. So I did that bit because that was my strength, because knitting is not my strength at all. So after doing that and participating in the group work, I then handed over to Kate for the big reveal.
Yes, they were going to love me or hate me by the end of the day. So I eagerly asked Rune how many people can knit, and I have to show hands. And it was pretty much like here now. There were no hands raised. I think one or two maybe that were willing to say that they could knit. So all of a sudden, this peer-to-peer learning that we were hoping to engage with as well had gone. My enthusiasm, although we're still high, my confidence levels at this point were getting quite low. But we're in for a penny, we're in for a pound, so off we go. We've got this, we can do it. So we started. We'd showed them some videos, we'd done a demonstration, and we'd peppered the room with our little volunteers that were eager to help. And we were in, weren't we? We were all in at this point. So they had some instruction. We produced some A3 laminates for them, showing them step by step what they needed to do. And we were ready to mingle. Luckily, what we got was a lot of smiley faces. So even though I think their apprehension when we said knitting was pretty evident, they all really got involved, and they were all happy to give it a go. And I think the smiles that we had around the room told us everything we needed to know, which was really good. We were really happy. And you can see in the photos as well, we've got our little helpers there, spreading the word and helping the students. And it was really good. I think it's one of those things with knitting, why I feel quite passionate about it, is if you're struggling at any point, because you're busy knitting or you're busy counting, and I don't class myself as a master knitter by any stretch of the imagination. I would say that I'm enthusiastic. I'm an enthusiastic knitter. But if you've got something that's playing on your mind, I think it's much easier sometimes to talk to somebody that you haven't got the eye contact with. And I think this kind of facilitated that. We were sat next to each other and we could talk about all sorts of things. Not only am I doing this properly, but we could have wider conversations. And I think that session really facilitated it. And because the pressure was on, we cast on, we literally just wanted people to knit. We were showing them one skill, and we weren't even bothered if they made a square. If it was squarish, that was fine. We would cast on for them, and we would add it to the pile. And surprisingly, as the session went on, the pile grew. So we were pretty happy with that one.
And I think also that the session itself turned out to be really positive, and it turned out to be better than what we thought, because I then found out Hannah and Katie could knit. So then it was a case of, we hadn't had that conversation before, so I'm going to move Hannah. I'm going to go and say, I'm going to struggle over here. Because, you know, AT is a big cohort, and sometimes when you make your own your friendship groups, you don't mingle as much with the other cohorts. And this kind of broke down that, because we were moving students around, people were engaging, we were having the conversations around the room, people were chatting to our henna group members.
I've now got a contact for spinning, so I can spin my own yarn going forward.
So it was very, very positive, and the students, I think at the end of it, because we run it twice now, this is the students and you had it last year with me today, and it was really positive, and the 2 times that we run it, it's been positive both times in relation to the students being open to it. And I think that's a tribute to them as well, because sometimes we'll say, you have to just go with us for this. It's a bit left field, but just trust us, just go with us. And it was really, really positive.
I think by lunchtime, after the first session, I think my confidence was back up.
Yeah.
I thought we can do
yes. And like I said, in terms of the vibes that we had, Amanda, who was our principal lead, came over. She wanted to knit a square. Darren came over. I don't know if Darren ever managed to knit a square, but he came over. He did a line. I think
Betty's mum kept on unpicking.
Yes, but everybody, you know, all the different lecturers wanted to come in and pop in during the day just to have their square done, and it was really, it was everything that we wanted it to be, and really in the essence of social prescribing, it turned out exactly what it needed to be and to hit the right boxes in terms of conversations, just socialization, doing something different and producing something at the end of the day.
People that you haven't spoken to before.
Which was great. Yeah. So Ella was meant to be with us today, but she is sadly unwell today, and she does apologise. But Hannah and Kaylee came last minute with us as well. Do you want to say anything about this, Asha? We're landing this on the. You don't have to. No pressure.
I would just say, like, very much in agreement with everything that you've said about the communication and speaking to people that you haven't spoken to before. Like, the room that we use for our lectures is like some sit at that end and some sit at that end, and you never see each other. And me and Hannah are a good example of that, because we're second year students now. We didn't speak to each other at all in first year, because Hannah was one end and I was the other. But yeah, I was one that already knitted at home. I actually like to do it in my free time anyway. But
you were going to go squares when you were a couple of days.
Yeah, it was nice, like, just to be able to talk to other people, and it was something different that, like, I never thought I would be sitting with my cohort knitting, and then there we were. But I really enjoyed the day, and I think it was beneficial.
It was a great opportunity as well to have the ladies come in and knit with us as well, as a generation gap between us. And as someone that was sitting there with things on my mind, not having that eye-to-eye contact with someone I didn't know, and that spoke the same language as me in Welsh, gave me the confidence to actually get those feelings out and speak to someone about them, and it just got rid of that weight off my shoulders. And I think that's what we as student knitters forget at times, is that if we can't look after ourselves, how are we meant to look after someone else? Especially when we're on placement, and it's tiring at times, but I think we do have to remember that if we turn to something like this, and maybe we do it with a friend, just not having the eye-to-eye contact is crucial, I think, to just let those feelings out. Sometimes it can be a bit awkward, but no, that day was definitely so beneficial. I know it's not just myself that said it, Kaylee said it, and several others have agreed that it's definitely something I think a lot more universities should take on. Yeah. No matter what you're going into, it's definitely something that should be a wider thing.
Yeah. And I think Ella, when she was knitting, she was so excited. She was texting her grandmother, wasn't she? Yeah, she was videoing me. Yeah, guess what I'm doing today? I'm knitting. And she continues. And she continued. She'd never knitted before that day. And she went to shop. She actually asked where we got the wool and the things from, and she went there after the session and bought them. And I think some of her friends who was in the middle slide there with Kay's, they spent the weekend knitting. Yeah. They did a group and they spent the weekend knitting. So it kind of achieved everything and more that we were hoping to do. So the impact, the excitement was really enthusiastic within the room. It fostered those conversations, and it was just really creative and enterprising. A lot of our students, they learned new skills. Some will never knit again. But you know, they learned something and they had to go, which was something. And from an enterprising point of view, there was one student, I can see him now, he was really, really struggling. So he subcontracted his work to somebody else. I'll come and sit by you. You can knit my square and I'll chat to you. So they were getting really creative, and again, it was just that with that element of talking to other students. So we had that social model of health element from a very immersive point of view, and it also, like Hannah's talking there about her own well-being, but actually they've got that permission now to think differently when there's nurses, and they've got perhaps who's also patients who need something different. So that permission there is out there to be creative and think differently. It is a bit of an enterprise in the circular economy because we have now blankets. So each cohort from now on has what's called a cohort blanket. And the students then sell a raffle ticket. So it's £1, so we're not expecting anybody to go into any hardship at all. So it funds the next year's social prescribing project. So it's a bit of a circular economy for us within the social prescribing sort of group that we have now got in terms of our nitty-gritty project. And it's in terms of the raffle tickets, I think they were initially asking if we were going to do live auctions because people wanted to bid for them, and it gone really, really big. So we were sticking with just raffle tickets just because it's a student cohort blanket. So we didn't want anybody to not be in a position to be in the mix to win it.
The cohorts were really well behaved as well because they didn't sort of say to the next cohort, you're going to be diminished.
Yeah, they were good.
Even in the morning. Yes, I've been in the morning and when we were leaving, you're like, don't
tell anybody. That impact. But after the session, like I said, we've run it now for 2 years, and the whispers within the university setting was really, really positive, but it has kind of rippled out more nationally. So I mentioned about One Health contacts. So I was invited to the NHS Planning Conference last year, and it was a very surreal experience because, you know, it's little old me from Aberystwyth, and I'm in that picture there with Professor Charles and Professor Nigel Holt from our psychology department, and I was presenting this, and they were presenting some of their psychology projects. And we're being, you know, asked to go to Cardiff to present this. It's quite a surreal moment. The One Health element has also reached the Future Generations Act office. I know they've reached out wanting to know more about it. Our RHCW Health Education Improvement Wales, that it features in our reporting to them as well. So the impact of our little plan B that has gone quite sort of nationally, which is really great to see because it is so important. And ultimately,
this is what these guys achieved in a day.
Oh, wow.
Yeah.
and we should say,
I'm proud of them. So yeah, these guys.
there we go.
This is from a bunch of monitors.
Yeah.
Large.
And what we will say is that everybody that attended the session, whether it was the HEC staff or all the students, and not all the students managed to do a square, but again, our henna ladies, they finished everybody's square. There we go. That's okay. So the henna ladies finished everybody's square. So everybody who participated on that day, they're in that. It's represented in that blanket, and that is their cohort blanket. So it's a bit of a big achievement, and something really positive. And we're going to keep doing it. We're going to keep doing it. Yeah. So thank you very much.